you for the live webinar, invites you for the live webinar on dermal challenges in obstetric and gynae practice. In fact, before I just go into the details, I would just like to talk a little bit about the company and our parent company, Acumes, as such. Now, Acumes Drugs and Pharmaceutical Limited, doctors, is our parent company. Now, incidentally, Acumes is the largest contract manufacturing pharma company of India, and we deal in the manufacturing and export of formulations in a wide spectrum of dosage forms and therapeutic segments. And company is currently supplying to almost all Indian and multinational pharma companies across the globe. In fact, a lot of brands you are using of other companies, whether multinationals or Indian companies, are being manufactured at our Acumes plant. And our 13 plants are located in Haridwar, and it is also known as today Acumes City, basically. And the division which we are representing, of course, is called Harmonica. And the vision of Acumentis is to become a global healthcare company, empowering each and every patient on the earth with novel healthcare solutions to fight their discomforts. We have 9 strategic business units. Of course, the major is the women's healthcare, cardio-diabeto, ortho, pedia, derma, and general. And our division, as I have told, is called Harmonica, which brings harmony back to life. And we deal in women's healthcare through gynae and obstetrics and IVF. Quickly, I will just take you through our product range, basically, which we have. Like, we have the entire basket of PCOS at your perusal. I mean, if you start with Ushore M, which is our minoanisotol and decairo with metformin 500. This is, of course, for PCOS-induced infertility. Then overweight and obese PCOS, we have Ushore 4. For lean and adolescent PCOS, we have Ushore Plain. This is minoanisotol 1 gram. And of course, for improving oocyte quality in ART cycles, we have Ushore Plus. Followed this with the brand of DynoFirst. This is DCGI approved India's first DynoGest. DynoFirst, of course, the first choice in pelvic pain associated with endometriosis. DynoFirst is followed by Fibroease, our next brand. This is a low-dose mifepristol 10 and 25, manages fibroid with weeds, which is the pioneer and #1 brand. The IVF therapy brands includes Clomipure 25, which is a clomiphene citrate 25 with melatonin 3 milligram. Clomipure 50 and 100, again with melatonin 3 milligram. And Clomipure L is a letrozole 2.5 milligram. The entire basket of clomiphene citrate. Endothic is our estradiol valorate 2 milligram tablets. Ovafem Plus is our micronized DHEA 75 milligram and reduced CoQ 75 milligram tablet. So, and to conclude with our Michelle range, this is our micronized progesterone, SR 200, 300, Michelle AQ injection, our progesterone 25 milligram, and Michelle gel, which is also there. So that is in a nutshell our product range. Now, I take the pleasure of introducing my moderator and speakers for today, and nothing can be more enriching than this. I take the pleasure of introducing Dr. Ritu Santwani. She is the director, Pune Test Tube Baby Center and Sham Well Women's Clinic, Pune. Honorary Professor, WIMS Medical College, Gajrula. Panel Consultant, Ruby Hall Clinic and Inamdar Hospital. She has 20 plus years experience in OBS and gynae and IVF, along with specialization in cosmetology. She is host and keynote speaker for more than 1,000 plus webinars, summits, training session, and public awareness sessions. Dr. Ritu has published more than 200 plus articles and columns for various health journals and newspapers, and she is associated with the World Society of Cosmetic Gynecology and a board member, India. She is the Vice Chairman, Board of Director, Middle East Association of Aesthetic Medicine and Reconstructive FGM Surgery. Welcome, Dr. Ritu, to the webinar. I go over to my first speaker. Of course, I take pleasure in introducing Dr. Anil Ganju, Senior Consultant Dermatologist and Laser Surgeon. Dr. Anil is the recipient of the prestigious Dr. Sardari Lal Memorial Lifetime Achievement Award, awarded by the IADVL and DSB. Awarded the ET Inspiring Dermatologist of the Year 2019, DAAS Dermatology of the Year 2018, IADVL President's Appreciation Award 2017, and Inspiring Best Medical Aesthetic Practitioner India by Professional Beauty Group 2020. Dr. Anil heads the departments of dermatology in several prestigious Delhi institutions. Presently is the president of SAR AAD, past vice president of IADVL, national and past president IADVL DSB, scientific chair aesthetics, has 12 publications in national and international journals to his credit, and Dr. Anil has authored more than 30 chapters in several textbooks of dermatology, cosmetology, and lasers. Welcome, Dr. Anil, to today's webinar. I now take the pleasure of introducing my next speaker, Dr. Shetty, M.K. Shetty. Dr. Shetty is a consultant dermatologist and aesthetic laser physician at Dr. Shetty's Aesthetics and Vikram Hospital, Bangalore. He has a fellowship in dermatology and laser surgery, has experience of 3 decades in dermatology, and the last 2 in aesthetics, IADVL task force member for setting guidelines in dermatosurgery. Dr. Anil is contributing author, ACS, textbook of cutaneous and aesthetic surgery, trainer in aesthetic dermatological procedures, and Dr. Anil and Dr. Shetty's areas of special interest are lasers, energy-based devices, injectables, and threads. Dr. Shetty, welcome to our webinar today. And my next speaker, Dr. Meghna Gupta. She is the director and senior dermatologist, Delhi Skin Center. She passed from Bija Medical College, Ahmedabad, India. She's 1 year had from 2002 to 2003, had a 1 year Rotary internship, 2003 to 6, 3 years residency in dermatology, 2010 to 12, senior consultant dermatologist at Asian Roots, New Delhi. 2007 to 10, she was a consultant dermatologist at 3 Graces, New Delhi, and 2006 to 7, she was a consultant dermatology, Kaya Skin Clinic, Delhi. She is a member of Indian Association of Dermatology, Venerology, and Leprosy. Dr. Meghna, she had participated in Medical Aesthetic International Certification Program, the HIFU module in Malaysia 2021 September, and Dubai Derma 2018 at 11th Asian Dermatological Congress. Dr. Meghna is an active member and faculty in many national events like advanced courses in aesthetics and dermatosurgery, research results, skin and scalp symposium, short pulsed laser workshop, and workshop on medifacials at 6th DAS Summit, and of course, 4th Acne India Summit, New Delhi. Welcome, Dr. Meghna, to our webinar. And of course, I now hand over to Dr. Ritu to take over the proceedings and get on with the program.
Thank you so much, Subhajit ji.
Thank you.
Will you please stop sharing? Yeah. So a very warm welcome to all our delegates and faculties. I want to especially give my thanks to Dr. Anil Ganju sir, Dr. Shetty, and Dr. Meghna Gupta. We are honored to have you here, all the stalwarts with us. So I am able to see in the delegate list also so many doctors have joined all across the geography. So very warm welcome to all of you. So friends, as we all know, the September month is the PCOS awareness month. So in our practice, because the topic of today is the derma challenges in obs and gynec practice, we gynecologists getting what are the problems in our practice related to this cosmetic. So this month, when Subhajit ji approached me, so I find this is a very good time because September month already a PCOS awareness month. And in the PCOS incidence is approximately, but we are getting from 2.2 to up to 26%. And patients are coming, PCOS is considered as a thief of womanhood. And we are getting patients with lot of cosmetic complaints, with the acne, with hair fall, with hirsutism, lot of other complaints. So I think I will hand over the dais to Dr. Anil Ganju sir, who is the master blaster for this. Over to you, sir. First, sir will take the conversation over this. Then I will ask some questions related to this. A very warm welcome to you, sir.
Oh, thank you very much, Dr. Ritu. It's such a wonderful pleasure to be on this platform. You know, I always like interdisciplinary, webinars. We do webinars in our specialty every now and then, but when it is interdisciplinary, there's so much to learn. You know, while we do our webinars, we think that we know everything about the other specialty, but then when we interact, we come to know, I am not able to make this full screen, just a moment. We come to know that there's a world everywhere in all these specialties. There's a huge science in every disease, every specialty, subspecialty, so much to learn. So here I am to tell you about the acne, hirsutism, and hair fall, particularly patterned hair loss in patients of PCOS. You all see PCOS. And today also I came to know, Dr. Ritu, it's a PCOS month. I didn't know that also. So much to learn, you know. So friends, polycystic ovarian disease, you all know, nothing to teach you here, is a heterogeneous clinical syndrome of hyperandrogenism and ovulatory dysfunction with a typical ovarian morphology on ultrasonography. This is supposed to be the commonest endocrinopathy in women. About 8% if we take just the clinical criteria into consideration, and if the ultrasonographic criteria are taken into consideration, about 22% of the women across the globe will be found to have polycystic ovarian syndrome. So extremely common. They have a range of symptoms which includes menstrual disturbances, signs both clinical and biochemical of androgen excess. They have metabolic syndrome, they have hypertension, diabetes, and these are very areas of interest now. All patients of PCOS are to be monitored for metabolic syndrome, hypertension, diabetes. You all know they are very obese usually, so they have all these problems. The diagnostic criteria have been changing over the years. In the 90s, the National Institute of Child Health and Human Disease gave the diagnostic criteria, where they included menstrual dysfunction, but did not include the polycystic ovaries. The Rotterdam criteria in 2003 included the polycystic ovaries, but did not consider hyperandrogenism an important part. And finally, the Androgen Excess PCOS Society in 2006 considered all of them together. Putting all this together, the Rotterdam criteria has been more or less widely recognized as a criteria for diagnosing polycystic ovarian disease, which includes ovulatory dysfunction, polycystic ovaries, particularly picked up on transvaginal ultrasonography, and clinical and biochemical evidence of hyperandrogenism. So if we have these, then we make a diagnosis of polycystic ovarian disease. Now, this happens in people who have a genetic predisposition to unregulated steroid hormone synthesis within the ovaries. There is increased ovarian theca cell activity. This leads to anovulation. Anovulation induces a negative feedback onto the hypothalamus, because the OVA not produced, hypothalamus produces more of gonadotropin releasing hormone, which releases the luteinizing hormone from the pituitary, and that induces androgen production within the ovaries. So the androgen levels rise. As the androgen levels rise, there is again anovulation happening and further negative feedback happening, and a vicious cycle sets in. Add to this a scenario of obesity, which is associated with insulin resistance and raised insulin levels. The raised insulin levels lead to decreased sex hormone binding globulin production from the liver, which leads to increased free testosterone levels in the peripheral blood and adds to a hyperandrogenic state. So all this put together, the patients of PCOS have one, polycystic ovaries and an androgen excess, and thus signs of hyperandrogenism. So dermatologically, they present with features of hirsutism, which is excessive hair growth on androgen-sensitive areas of the body. They have acne that does not respond to our conventional treatment. They have androgenetic alopecia, that is patterned hair loss over the androgen-sensitive areas over the scalp. They have seborrhea because of excessive sebum production, and they have features of oligomenorrhea, obesity, infertility, metabolic syndrome, diabetes, hypertension. All that is common in these patients. Now, how does acne happen in patients of PCOS? The circulating androgens get converted into testosterone, and testosterone further gets converted into dihydrotestosterone at the tissue level. There is increased enzyme activity of 5-alpha reductase enzyme at the tissue level, which converts testosterone to the more active form, the dihydrotestosterone. Testosterone and dihydrotestosterone together have receptors on the pilosebaceous unit in the skin, which gets stimulated. So once the pilosebaceous unit gets stimulated, there is increased sebaceous activity, lots of sebum is produced, and acne sets in. And it basically creates an environment for the Propionibacterium acnes to grow, and then inflammation sets in and acne results. The androgens also stimulate the hair follicles in the androgen dependent areas, the so-called androgen dependent areas where the hair is stimulated by the androgens include the jawline, the upper lip, the central areas of the chest, the areolae in the ladies, and the inner thighs. And here the androgen stimulation leads to conversion of the soft vellus hair into coarse terminal hair, and thus leading to hirsutism. And interestingly, these androgens, the same androgens, have a negative effect on the growth of hair follicles over the scalp, over the frontal area and over the temporal area, which are the androgen sensitive areas, because of which there is hair loss and development of pattern alopecia in women with androgen excess. So let's go to acne and PCOS. Most of the patients of PCOS will have some degrees of acne, and we suspect PCOS in acne patients when our patients do not respond to our repeated courses of antibiotics, to other therapies, particularly to isotretinoin, which is actually a wonder drug. All the patients have to respond to isotretinoin. If they don't, then we suspect that acne could be a hormonal acne happening because of an underlying hormonal disturbance, which most commonly is PCOS. When there is a disturbed menstrual history, we suspect PCOS. When there is a premenstrual flare of acne, then also we suspect PCOS. And when there are other features of hyperandrogenism, like we could be having hirsutism, frontotemporal balding, signs of insulin resistance like pseudoacanthosis nigricans, excessive skin tags, increased number of moles, angiomas, cherry angiomas, all that means that the patient has high levels of insulin in the circulation. There are several studies that have now shown that acne is rampant in patients of PCOS. The reported prevalence in PCOS ranges from 9 to 34 across various studies. And in adults and girls, mild to moderate to severe acne is reported in more than 50% patients of PCOS. So when we have resistant acne and patients are obese, patients have menstrual disturbances, then we suspect PCOS as the underlying stimulator of acne in these patients. One of the studies showed that 19% of the acne patients met the diagnostic criteria for PCOS. So that means that some degree of PCOS is seen in all patients of severe acne that is resistant to treatment. Another study found that 37% of women with acne have menstrual disturbances, have elevated levels of luteinizing hormone, and a disturbed ratio of LH, FSH, and polycystic ovaries. So all this put together, most of the studies have shown that acne with PCOS is a huge problem. So how does it happen in patients of PCOS? The androgens enlarge the sebaceous glands. They increase and stimulate the sebaceous glands to produce excessive sebum. There is abnormal desquamation of the follicular epithelial cells also. So the androgens have a direct effect on the follicular keratinocytes. They have found the receptors to androgens on these follicular canal cells also. So they hyperproliferate and then they desquamate into the canal, cause plugging within the canal and lead to formation of comedones. In this environment of excessive sebum production and an anaerobic environment because of blockage of the canal, the anaerobic organisms like Propionibacterium acne proliferate rapidly. They produce inflammation by themselves and by production of various inflammatory mediators. There is progressive development of papules, pustules, nodules, cysts, etc., which can later on lead to formation of scars. So that's how androgens stimulate formation of acne. The treatment conventionally is oral and topical antibiotics, oral and topical retinoids, benzoyl peroxide, dapsone, azelaic acid. We do procedures like chemical peels, lasers, lights, microdermabrasion, etc. But if there's an underlying PCOS, then we have to look at PCOS and treat PCOS. Unless we treat PCOS in these patients, we do not get a favorable acne outcome of the acne. So the acne do not respond well to all these measures unless we treat PCOS, if PCOS is present in the patient. The topical retinoids, when applied, normalize the follicular desquamation and reduce inflammation. They also have a sebostatic effect. So retinoids are one of the best topical treatments in acne because they, one, reduce sebum production, which is one of the pathogenic mechanism. They normalize the follicular desquamation, another pathogenic mechanism. They also are anti-inflammatory, another pathogenic mechanism. In fact, they are antibacterial also to some extent. They reduce the proliferation of Propionibacteria indirectly. So retinoids is one drug which has multifold effect on various pathogenic mechanisms in acne. Topical antimicrobial agents are used as antibiotics and as anti-inflammatories. And antibiotics like erythromycin, clindamycin, particularly in combination with benzoyl peroxide, are used. Benzoyl peroxide is a very useful adjunct because it reduces the likelihood of development of antibacterial resistance, which is quite common these days. And topical dapsone has recently emerged as a very useful antibacterial and anti-inflammatory agent, particularly because no resistance has been reported to benzoyl peroxide 1. And benzoyl peroxide, in fact, reduces the development of resistance in Propionibacteria to other antibiotics. So it's a very useful drug. There is this combination for the benefit of our gynecologist friends. There's a combination of dapsone and adapalene available and dapsone available. Dapsone available as 5% gel standalone or in combination with adapalene is very useful as an antibacterial and anti-inflammatory and comedolytic agent in patients of acne. There are several studies available. Dapsone has proven its mettle. In one of these studies, 93 women aged 18 plus had moderate to severe acne and had sensitive skin. So what happens in sensitive skin? Most of the topical agents that we apply produce irritation. So dapsone in these patients, when applied twice a day over a period of 12 weeks, showed that there was a good reduction in the inflammatory acne. Most of the women felt good about the application because their self-image improved. And the good thing about it was they were comfortable. There was no irritation as far as their sensitivity was concerned. So 5% dapsone seems to be a very good local application, acting in mild to moderate inflammatory acne, particularly in patients who have sensitive erythematous skin. A combination of adapalene and dapsone has further advantage because, as I told you, dapsone is an antibacterial and anti-inflammatory. Adapalene is a comedolytic. These two put together gives an additional advantage in patients of acne. So this was one of the studies which compared dapsone alone with dapsone plus adapalene in 203 patients of 12 years plus acne patients, divided into 2 arms, and treatment given over 12 weeks showed that both inflammatory and non-inflammatory acne did better with a combination of dapsone and adapalene compared with dapsone alone. You can see the darker bar is the ones, those who are treated with dapsone and adapalene, better response, better reduction in the acne. So therefore, the combination of dapsone and adapalene is a very useful and a better combination in patients of acne. The other manifestation of PCOS is in patients is hirsutism, which is the abnormal and excessive growth of terminal hair over the so-called androgen-dependent areas. So the androgen-dependent areas are the sides of the face, the jawline, the upper lips, the central part of the chest, the areolae, and the inner thighs. So these patients get excessive terminal hair growth here. Ladies normally do not have terminal hair here, but stimulation of androgens leads to development of these hairs. And most of these patients of hirsutism have underlying PCOS, and in fact 50 to 80% of the PCOS patients will have hyperandrogenism and hirsutism in them, and the prevalence is seen in all ethnicities and all countries. This is one of the scoring system for hirsutism in patients of PCOS. It's known as Perelman-Galway scale. We score it according to the amount of hair in various androgen dependent areas. So what happens? Why does hair grow excessively in PCOS patients in these androgen dependent areas? Basically, the testosterone and the dihydrotestosterone alters the hair in its cycle. It irreversibly transforms the villous hairs into terminal hairs. So normally the ladies have villous hairs in these areas. They have hair, but they are thin and villous, but they are stimulated into terminal hair by the action of the androgens. The androgens act by prolonging the anagen phase, which is the growth phase in these areas of the body. And interestingly, they shorten this anagen phase in the frontotemporal areas, which leads to the loss of hair or decrease in the hair growth in these areas. So often we need to treat these patients with a combination of hormonal therapy for PCOS or other hyperandrogenic states and physical methods. The hormonal therapies take about 6 to 9 months to have an effect because the hair growth cycle is like that. So the patients are to be counseled about this. And then we do physical, treatments like depilatory methods. We use bleaching agents for thinner hair. We use topical creams like eflornithine hydrochloride alone or in combination with lasers to give a good effect. These are various physical modalities that are available, but thermolysis and electrolysis is more or less obsolete because it's a very cumbersome, prolonged process. So laser hair removal is a welcome boon for the treatment of hirsutism in patients. This progressively miniaturizes the terminal hair back into villous hair. It doesn't remove the hair for that matter. It just thins out the hair and decreases the frequency of growth. Then the androgenetic alopecia or patterned alopecia. In patients of PCOS, this is how it presents. There's an increased visibility of the parting at the vertex and the parietofrontal area. It can have a huge psychological impact on the patients who are affected. In women, it may be difficult to differentiate from other forms of alopecia. In men, we see it in a typical, receding hairline and development of hair loss over the vertex. So the combination tells us straight away, gives a diagnosis. But in women, they have a varied presentation. Sometimes it is difficult to differentiate it from other causes of hair loss like alopecia areata and telogen effluent. They have varying degrees of hair loss and they do not have typical, sometimes androgenic distribution of the hair loss. That's why it is known as female pattern hair loss rather than androgenetic alopecia. So hair loss happens because the hairs in these areas of frontal and temporal and parietal regions are sensitive to the androgens, but androgens have a negative effect on their growth. They progressively cause miniaturization of the hairs by prolonging the telogen rather than prolonging the anagen. So telogen is the hair loss or falling of the hair stage. Anagen is the hair growth stage. So because the telogen is prolonged, there is more loss of hair. And also following telogen, the getting back into anagen for the phase is also delayed. And all this leads to, hair loss and decrease in the hair in these areas. So there are several studies that show that patterned hair loss is very common in patients of PCOS. In patients, women with hyperandrogenism, 3.2% in one of the studies showed patterned hair loss, and other patients showed 4.7% incidence. Interestingly, some may have raised androgen levels, but many may not have. So which means that only androgens are not playing a role. The only treatment recommended is topical minoxidil. The US FDA approved treatment is only minoxidil, but there are a number of other, treatment modalities that have been tried, and one of them is this combination of Redensil, unitrinol, and dexpenthenol. This is a combination of peptides and sebum regulators and penetration enhancer. Redensil in this combination reactivates the stem cells, stimulates the fibroblast activity, thus improves the anchoring of the hair follicle. It also inhibits the 5-alpha reductase activity. We had talked about conversion of testosterone to dihydrotestosterone, which is responsible for hair loss. This it inhibits. Unitrinol in the combination regulates the sebum production, reduces the sebum production, because that's also one of the pathogenic mechanisms. And dexpenthenol enhances the penetration of these agents. So this is a double-blind placebo-controlled trial in 26 men of 18 to 70 years of age who had grade 3 to 4 alopecia. Baseline anagen to telogen ratio was calculated using trichoscopy and trichograms. The patients were randomized into 2 groups, and one group was given Redensil 3%. This was not a combination of the 3, just Redensil, and the other group was given placebo. And evaluation was done at day 0, 3, and 84. And there was a huge gain of 9% in the anagen count in patients who were receiving Redensil. Also, there was a reduction by 17% in the telogen count in the patients who were receiving Redensil. The anagen to telogen ratio improved over a 29% within 3 months of use of Redensil. So Redensil definitely improved the hair quality, hair growth in these men who were suffering from androgenetic alopecia. So these are the various photographic representations how it improved over a period of 3 months. Extra denser is a combination of Redensil, unitrinol, and dexpenthenol from Acumentis, which is helpful in this situation. So friends, the take home, PCOS is one of the most common endocrine disorders in women of reproductive age. There are many dermatological manifestations, of which common are drug-resistant acne, hirsutism, androgenic hair loss, disorders of pilosebaceous unit. Acne is caused because of the enlargement of the sebaceous glands, increased sebum production that is stimulated by circulating androgens. The androgens also cause abnormal desquamation of the follicular epithelium. Acne also involves Propionibacterium acne colonization and multiplication. Hirsutism happens in PCOS because of excessive hair growth of terminal hair in the androgen-dependent areas. Androgenic alopecia or patterned hair loss also happens because of miniaturization of the androgen-sensitive scalp follicles, shortening the anagen phase. There are also longer gaps between shedding of the telogen hair and replacement by the anagen hair. In all cases of PCOS with dermatological manifestations, we need to treat the underlying hyperandrogenic state also to get a wholesome outcome in the skin condition. Otherwise, the skin conditions do not improve completely. Dapsone in combination with adapalene is a very useful new addition to the anti-acne armamentarium. And Redensil in combination with unitrinol and dexpenthenol seems to be a very promising topical therapy for androgenetic alopecia, both in men and women. Thank you very much, friends, for your kind attention. Over to you, Dr. Ritu.
Yeah. Thank you, Anil sir. A very excellent lecture.
Thank you.
Yeah. Anil sir, there are 2 queries because some of my friends have just able to join now. So friends, don't worry. I'm going to take all the queries on the panel discussion. Sir, as you told now that the Dapsone is much better, the recent drug which has come. Sir, what's the regarding the safety of the Dapsone in pregnancy? Because we are getting so many patients, the pregnant patients with the acne, so retinol preparations we can't use. So regarding this Dapsone gel, can be used in the pregnant patients?
No, actually, it's not recommended to use any sulfonamide in pregnancy, even topically. But one thing has been found, dapsone in patients of G6PD deficiency, we are not supposed to use dapsone, but topical application has been seen to be absolutely safe. At least in that situation, it is recommended to be used, which means that probably systemic absorption is very, very low. But having said that, it has not been recommended for use in pregnancy.
So, sir, in pregnant patients, means routinely what I am using, the azelaic acid preparations.
Yes, azelaic acid, benzoyl peroxide,
Peroxide.
clindamycin, these are all safe topically.
Yeah. Thank you so much, sir. Sir, rest questions we can take on the panel discussions. So, friends, sorry, some of you have get a lot of difficulty in joining. I think now most of the doctors have joined. So request to all of you, please share the link to your other friends also. My chat box is full, more than 50-60 messages I've got that they are not able to join. So now coming to the next topic, that is regarding the pigmentary changes, hyperpigmentation during pregnancy. So friends, as we all know, in our practice, we are getting so many patients with this melasma and colasma. So that incidence is reported approximately from 54 to 90%. These days, as I am practicing in Pune and Dr. Shetty is from Bangalore, so many patients, all are coming, the tech savvy, the Google savvy patients are coming. Ma'am, due to this pregnancy, my whole complexion is going bad. I am looking so bad. So I always start counseling with them. Yes, there is a treatment. We will start your treatment because self-love is your superpower. So now what are the new treatments? What is the insight? We are going to listen first from the Dr. Shetty. Over to you, sir.
And Priyanka, are you loading my presentation?
Yes, sir.
Please.
A small announcement, friends, those of all of you want to get a certificate of attendance, please put your mail IDs in the chat box. Later on, the Priyanka will send the certificate of attendance to all of you.
Good evening to everybody on this online session covering dermatologic aspects of pregnancy. We've heard an excellent lecture by Dr. Anil Ganju, and I have a very hard act to follow. So my brief is to be speaking on pigmentary changes in pregnancy. And we, as gynecologists, I'm sure that you see women coming into your clinics with, of course, there are a few organ systems that are not affected by gestation, but on the outside, it is the skin that is a reflection of this fairly common entity of diffuse pigmentation. And it affects almost 90% of women to a lesser or to a greater extent. The modulating factors in large part tend to be hormonal, metabolic, or immunologic, and it is often a source of distress and concern to these pregnant women. Thankfully, most of these changes tend to reverse postpartum, but some patterns might persist in a less severe form, but the exact pathogenesis remains largely unclear. So this generalized hyperpigmentation is usually seen with accentuation of normally hyperpigmented areas such as the areolae, the nipples, the genital skin, but also the axillae and the face. Linea nigra is primarily a darkening of the linea alba. This hyperpigmentation is attributed to increased MSH, estrogen, and progesterone levels. The role of MSH is, of course, disputed as pigmentation begins in the first trimester of pregnancy and regresses during the postpartum period, while levels of alpha MSH are high during late pregnancy. The next slide, please. Progesterone levels tend to increase throughout pregnancy, while estrogen production increases from the 8th week onwards and starts falling around week 30. These patterns, additional factors include a greater population of melanocytes in the affected areas and reflecting a greater progesterone or estrogen receptor sensitivity. So if you look at the main patterns of, I would not necessarily call them disorders, but main patterns of pigmentation during pregnancy, they would be secondary areola, the linea nigra, dermal melanocytosis, pigmentary demarcation lines, melasma, of course. And of course, you also have darkening of pre-existing nevi and freckles. And also you might see certain nail changes such as longitudinal melanonychia, which tends to regress in the postpartum period. Acanthosis nigricans is a pigment-like entity, but it is not in the truest sense a form of a pigmentary anomaly. Secondary areola is darkening of skin adjoining, sorry, can I go back to the previous slide? Yes, it's darkening of the skin adjoining the areolae or between both areolae. Should be sometimes differentiated from nevoid hyperkeratosis of the nipple and areola, which is thankfully relatively uncommon. The next slide. Linea nigra. The next slide, please. Essentially, it's a darkening of the linea alba, extending from the pubic symphysis to the umbilicus, but sometimes extending to the xiphoid process. Appears during the first trimester of pregnancy, and it's more pronounced in those with a dark complexion. Pigmentary changes in general tend to affect those who are darkly complexioned. The linea nigra, sorry, the previous slide. The linea nigra is often accompanied by a displacement of the umbilicus to the right, called the ligamentum teres sign. It often persists postpartum until the abdominal muscle tone is regained. It's a consequence of pressure of the gravid uterus on the ligamentum teres and falciform ligament. The next slide, please. Dermal melanocytosis. It's a relatively rare thing, but it's often seen in the result of reactivation of pre-existing dormant dermal melanocytes by various hormonal influences. And of course, these tend to be an elevation in the estrogen and progesterone levels. And also an elevated keratinocyte-derived endothelin-1 and MSH tend to potentiate tyrosinase activity and stimulate melanogenesis. The next slide, Priyanka. Pigmentary demarcation lines. This is an abrupt, or it is defined by an abrupt transition from a more heavily pigmented area to an area of lighter or normal pigmentation. There are essentially 8 different types of PDLs that affect the limbs, the trunk, and the face. In pregnancy, you tend to see what's typically called a class B form of pigmentary demarcation line affecting the posterior medial legs. You might also see class A and was affecting the trunk, which are C, D, and E. The next slide, please. F, G, and H tend to affect the face. The mechanism of development is not clearly understood. In pregnancy, it has been suggested that type B is caused by compression of S1 and 2 nerves by the uterus, resulting in neurogenic inflammation, resultant erythema, and pigmentation along peripheral nerves of the leg. However, there does not seem to be any specific histological correlation. It could also be the result of specific peripheral nerves having neighboring melanocytes stimulated by increased MSH. The next slide, please. Melasma, which is by far one of the commonest problems affecting facial and also non-facial skin. It is reported in 50 to 70% of women. Again, those with, commoner in those with skin types 5 and 6. There is clinically 3 versions of this. There's a centrofacial, and that's the commonest pattern affecting the cheeks, forehead, upper lip, nose, and chin. The malar pattern limited to the cheeks and nose, and the mandibular affecting the ramus of the mandible. It is commonest on the face, but can occur in other sun-exposed areas and even non-sun-exposed areas. Although hormonal influences are involved, UV radiation and a genetic predisposition are important factors. Sun avoidance and the use of appropriate blocks is an extremely important initiative in the management and prevention, if I may use the term, of melasma. However, therapy in its truest form is best left for the postpartum phase, where often epidermal melasma in particular tends to settle, but not always. And while there are a host of topical applications available, it would best, in the interest of the patient, best to restrict usage if indicated and necessary, especially dictated by the amount of distress that's causing the patient. Use topical agents such as kojic acid, vitamin C, niacinamide, and azelaic. Hydroquinone, topical retinoids, butane are best avoided. Peels could be tried, especially the alpha hydroxy. Beta hydroxy is again best avoided. Could we have the next slide, please? Let's get this one. Priyanka, the next slide. Well, the nice thing about managing hyperpigmentation during pregnancy is there is apparently no urgency in trying to treat it. It is often a phase that they go through, tends to settle down in the postpartum period. Therefore, the most effective means of management in most cases is reassurance and explanation of the physiological nature of these changes. The next slide. So the factors to consider are the location and distribution of the pigmentary change. How likely is it to reverse in the postpartum phase? The degree of distress it causes the patient, which can often be considerable. The available safe treatment options during pregnancy and lactation. And the role of sun blocking in its management. So to summarize, pregnant women experience various physiological changes during pregnancy, of which pigmentary changes are among the commonest, modulated largely by hormonal, metabolic, and immunologic factors. It can be quite distressing, and most of these patterns of pigmentation are reversed postpartum, but might persist in a less severe form. The exact pathogenesis remains unclear, but increased levels of estrogen, progesterone, and MSH are likely precipitating factors. And the main entities that would follow in this category include secondary areola, linea nigra, reactivation of dermal melanocytes, pigmentary demarcation lines, melasma. Treatment can be kept for the postpartum phase. Reassurance and appropriate explanation of the physiological nature of these changes are the most effective means of management in most cases. And wherever appropriate, the use of products which are deemed to be safe in pregnancy should be instituted. Thank you for a patient hearing.
Thank you. Thank you so much, Dr. Shetty, sir. A very nice presentation. Thank you. Thank you. Thank you, Dr. Shetty, sir. So
Thank
now,
you.
yeah. So now, friends, we are moving to the third discussion, a very, very important topic, which the patients we are getting in each and every gynecologist obstetrician getting the patients of the stretch marks during pregnancy, which is a very, very common entity. From 43 to 88% patients will develop the stretch marks during pregnancy. So first we listen from our esteemed panelists with Dr. Meghna Gupta, and later on I will switch over to the panel discussion. A very, very warm welcome, Dr. Meghna. The dais is yours.
Thank you so much, Dr. Ritu. It's a very interesting topic indeed. And I'm so thankful to Acumentis for giving me this platform to share my views on stretch marks. Being into aesthetic practice, we get to see a lot of patients with stretch marks. And I always tell everyone, as doctors, apart from treating them with our interventions and our creams, lotions, tablets, a lot of counseling is required. A lot of counseling is required here. So I start with stretch marks. I always say the stretch marks were lightning strikes of life, providing she would weather the storm. So all women first should not get distressed. Yes, it does disturb the quality of life. They get psychologically impacted, but it's a beautiful thing. So don't get very upset with it. They also call striae gravidarum, a common disfiguring gestational change which affects between, as Dr. Ritu said, I would say around 55 and 90% of women. How do they present? They present as atrophic linear scars and can cause distress, leading to reduced quality of life. They're often overlooked as cosmetic concern. That's where our physicians, we play a role, where we guide them, we reassure them, we treat them. The current research in risk factors and prevention management has been limited. It's met with little success, and there are not many conflicting results. As I went through a lot of studies to present this presentation, I saw that there was not much studied literature on striae gravidarum. There are two kinds of them, striae rubra, and the other one is striae alba, and the most important, the area that we get to see is on the abdomen. And striae rubra we generally see, when they're just very active, and striae alba, as we all know, as these stretch marks become old, they change into this. So they first present as these flat pink to red bands, which become raised longer, wider, and violet. So this is what rubra is. A lot of women may present in early pregnancy also with these issues. And as over a period of months to years, they flatten, they become hypopigmented, and that's where they appear very parallel to skin tension lines. They look wrinkled, they come with laxity to the skin, they give white atrophic marks, and they're called mature striae as striae alba. Now I'll use little short forms here. Sorry, I'm going to take this liberty. SG can cause sometimes itching, burning, and discomfort. And that's where even you have to intervene if they are presenting with symptoms. Typically present on breast, abdomen, hips, and thighs. And up to 90% SG appears in primary gravidas. I'm sure you guys must be seeing this in your practice. And typically reported onset is in late second and early onset of third trimester. There are a lot of studies, as I said, where they said that 43% of women said that they will before 24 weeks of gestation. Now, what are the risk factors? Younger age group, which is, we always tend to see more problems with younger girls. Maternal and family history, we all know it. And higher pre-pregnancy and pre-delivery weight, where Dr. Ganju sir also said that, PCOD also seen in obese girls. Here also we see a higher pre-pregnancy weight or pre-delivery weight will lead to more striae and a higher birth weight. This is another study which said there's higher prevalence in non-white women, which, we all know that. Most studies associated with the history of striae on breasts, hips, and thighs. Other risk factors, which, apart from these which I just enumerated, were increased alcohol intake, decreased vitamin C levels, decreased water consumption, and expecting a male baby, So you have to guide them about increased hydration, which is achieved by two means for cutaneous changes. One is drinking enough water, another one is moisturizing. I'll come to that in subsequent slides, what preventive measures we can really take away. This is just a schematic presentation to show that these are the areas. Even knees and calves you started seeing in the practice, but most often we see it in the abdomen. If we go by it, family history develops stretch marks. So we see there increased chances of developing them. Birth weight, multiple births. Moms which expect multiple babies have increased chance of getting stretch marks. Many of them are using steroids. I mean, steroid creams, we had an idea while running a huge campaign against use of cortisons. When they're using these Betnovate and so-called other over-the-counter available steroid creams, thinking that this is one cream which will, answer all their skin concerns, we see that there's increased chance of development of striae, maternal age, we have discussed, weight gain, and sometimes there's a mechanical stress, which I'll talk about pathophysiology, that how this is developing into these SGs. Though it's very unclear, still we all know medically that components of the ECM are suspected of the underlying development of SG. ECM is extracellular matrix. It's generally believed that collagen bundles can be damaged by this, which gives a very pulled apart, like a tension bands due to this intense skin stretching as the elasticity of the skin is compromised. The dermal ECM, which is the extracellular matrix, is unable to adapt to these stretch marks, and especially in the susceptible populations. It is seen to be shown to evolve abnormalities of various components, which is elastic fibers, collagen fibrils, and other ECM components. The type 1 collagen fibrils provide strength, support, and resilience to the skin, which get damaged in trying to accommodate. And elastic fibers form a reticular structure, and that's what maintains elasticity. That also gets disturbed, and hence the striae are formed. The mature SG, they resemble atrophic scars. A lot of times, I will talk about it in subsequent slides, how we do various procedures to really treat the way we treat acne scars. So they look thin or reduced elastin fibers in collagen bundles, which lie parallel to the epidermis. Higher expression of estrogen and these androgens and glucocorticoid receptors. The glucocorticoid surge inhibits activity and proliferation of fibroblasts. So we see there's reduced number of elastic fibers in collagen, and there's a prevent which completes repair of damaged connective tissue in the dermis. Dermis is where the collagen lies. That's the middle layer of the skin, and that's what it does. I always tell my patients when I talk about striae that your body is not ruined. You're a fearsome tigress who has earned her stripes. So first get that clear, and that's where we move on. Coming to the management, it's a lot of counseling, as I earlier said, which you have to give. There are many studies done on the topical creams and lotions which are available over the counter or prescriptive, talking about preventive or to prevent stretch marks. They really don't prevent, but yes, they can help in reduction the appearance of the stretch marks. That is why there are very few limited creams and lotions which are available. You must initiate the treatment during early stages of pregnancy rather than waiting for them to become striae alba. In fact, I always say post-lactation, if you treat your stretch marks within first 2 years of appearance, the aesthetic outcome is much, much better. There are many women who present like 10 years down the line after their delivery, and then, management of stretch marks actually become a very tough condition. What options do we have as physicians? Either we talk about topical medications, or we have certain energy-based devices, lasers, and light options. In topical management, tretinoin, we discussed retinoids. They are really a wonderful thing for acne scars, and even for stretch marks. For body, what we like to use is 0.05 to 0.1%. They have to be used consistently. They do not show results within few weeks, only after usage of 3 months, sometimes up to even 7 or 9 months, that you see that overall there's a reduction in SG. What it does, it decreases the mean length and width of the lesions. Sometimes we like to combine them with AHAs, which is alpha hydroxy acid, which is a glycolic acid 20%, and even 10% ascorbic acid, commonly known as vitamin C. When you combine these sometimes all together, which you have to sometimes prescribe a glycolic alternate with tretinoin, if you give them together, they can cause a lot of irritation. So when you prescribe such medications, you have to again counsel your patient that don't start using too much. You have to start building it slowly. Start with, let's say, 1 pea size, just put it in the area of stretch marks. You have to moisturize immediately. And otherwise, there can be something called retinoid dermatitis, which may develop, and the patient will again present back in the OPD with a rash, we can call it, or retinoid dermatitis. Coming to laser treatments, there are non-ablative lasers like CO2 laser and fractional erbium YAG laser. What it does, it stimulates the fibroblast activity and causes collagen remodeling. So you can sometimes combine with other treatment options. Only thing you have to counsel your patient that there's a downtime involved, where the downtime, the skin looking erythematous, swollen for good week to 14 days. Then there are non-ablative lasers, which is fractional erbium glass laser, which can reduce the appearance of this striae. Excimer lasers, which is particularly effective in the, when there is increased pigmentation, and pulse dye lasers, which is, which can be presented as the gold standard for the vessels, when vessels also become prominent. And there are many other lasers which, not commonly used in the practice. Commonly used treatments, which is light treatments, which is not really a laser, it's called intense pulse light, which seems to have moderate improvement in the striae, and sometimes persistent erythema and PIH. In Indian skin, the problem in treating most of the issues is post-inflammatory hyperpigmentation. So apart from treating stretch marks, you have to really see on your patient if the patient is developing PIH, which may complicate the treatment. So there, where you need to counsel them and explain them usage of sunscreen if we are using the treatment of stretch marks on visible areas. Sometimes UV lights like UV and UVB can be really combined, but results are not permanent and maintenance treatment is needed. Then infrared light, which is 800 to 1800 nanometer, showed 25 to 50% improvement, but there are long-term studies which are required with bigger sample size. This is just a little schematic representation to really see how we take a full medical history. We talk about family history, is it there or not? What kind of symptoms and signs we are seeing, whether it's an anatomical location, the physical and the psychological impact on the patient. Patient needs treatment if psychologically impacted. You examine, you divide them into fits. We all Indians are majorly Fitzpatrick 4 and 5 skin types. And then you decide, you manage whether you want to do just the topicals, you want to do a laser, you want to do a light therapy. You counsel them. There are multiple sessions required. You assess, reassess, and pictures are very important. Photography is an integral part when we treat stretch marks. This is one of my young patients, 27-year-old, who, after delivery, she presented almost 6 to 8 months later. And, Dr. Ganju sir would agree, MNRF, microneedling radiofrequency, one of my favorite treatment, which I will include how I approach. And just after 2 sessions, we saw a very great aesthetic, outcome of the treatment. How I approach, what we were just going through was what we see in the literature. But in my practice, I am very, very fond of microneedling radiofrequency. The downtime is hardly 2 or 3 days. Yes, there are multiple sessions required, probably 4 to 6 sessions, 4 to 6 weeks apart, but it helps. Second is fractional CO2. I like to use it in, which are older stretch marks, as we discussed, try alba, where sometimes people present with, they want it to be treated. Retinol peels, which are easily available. You can counsel your patients. There are 4% retinol peels, which again have a downtime of little flaking and skin going dry. Series of 3 to 5 sessions, 3 weeks apart can be planned. I have done platelet-rich plasma, which is commonly known as PRP, not standalone, but in combination with retinol peels and MNRF. And I saw that the outcome was little better. Yes, anti-stretch mark creams should be prescribed, which generally contain tocopherol acetate, dimethicone, allium cepa, which is onion extract, and calendula extract. How I would like to summarize is stretch marks in pregnancy, they're called striae gravidarum. It's a common disfiguring change which presents as atrophic scars and really cause distress to the patient. Pathogenesis is not clear, Early SG presents with loss of collagen bundles, including thin disordered elastic fibers, and mature striae, they resemble atrophic scars. High expression of estrogen, androgen, and glucocorticoid receptors are reported. Several risk factors, if we go through it, which we must include when we really design a roadmap for our patient, what we like to do and what we would like to do. Being a mom is worth every stretch mark, wrinkle, and sleepless night. I always tell all my patients, I'm a mother of 2. This is a 5-year-old picture. I have stretch marks. I was treated with MNRF. I think I'm good to go. So I would say thank you so much for the patient hearing. I'm open to any questions. I'm sorry it was short and crisp because there is not so much, still studies are still going on, not so much to discuss. Thank you so much.
Thank you, Dr. Meghna, for a very, very crisp presentation. Thank you so much.
Thank you, Doc. Thank you.
Can you please stop sharing the screen?
Yes.
So friends, I am very much delighted to see that so many friends have joined all across the geography. I am able to see the friends have joined from Lebanon, Egypt, Iran, Iraq, Dubai, Nepal, and Bangladesh. Dr. Kariman is president of Lebanon Society. She is also here. A very, very warm welcome. So friends, I hope that all the sessions are going to be very useful for all of you. So now I am going to start the panel discussion. So friends, please be actively participate in the discussion. With the permission of our esteemed panelists, shall we start the panel discussion? Dr. Ganju sir, Dr.
Yeah,
Shetty sir, Dr. Meghna.
Yes, please.
Yeah. So I've started sharing my screen. So friends, those who are joined late, so please don't worry. I'm going to cover each and everything on the panel discussion. Making it full screen. So my every presentation will start. We have just gone through 2 bad phases of Corona. So my presentation will always start with this Stuti to Ma Durga, whom I worship, and my everything will start with the worship of the goddess Durga. Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasei 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 Namo Namah. So friends, as we are having with us the 3 esteemed panelists with us, Dr. Anil Ganju sir, Dr. M.K. Shetty sir, and Dr. Meghna Gupta. So I am trying to cover each and everything because those who have joined late have missed some important points which have been covered in the lecture. So as just now sir has mentioned regarding this cholasma, so as we all know, this cholasma is a required hypermelanosis of sun-exposed areas occur during pregnancy, and it can affect 50 to 70% of pregnant women. It presents as a symmetric hyperpigmented macules which can confluent or punctuate. The most common locations are the cheek, the upper lip, the chin, and the forehead. So, coming to the first question. So, with our esteemed panelist, Dr. Ganju sir, I am putting this question to you. That what's your choice for the treatment of this hyperpigmentation during pregnancy?
Okay. During pregnancies, the choices are limited because, contrary to the belief of the patients that they can apply anything on the skin, there are so many things that should not be applied and are not recommended to be applied. For example, hydroquinone, retinoids, salicylic acid. These agents are not to be applied during pregnancy, are not recommended in pregnancy. So these are common agents that we normally use for melasma but can't apply. What we can, and I believe that we should follow the dictum that Dr. Shetty, talked about in his talk. He said it's better to wait for the pregnancy to go, and there's no urgency for treatment, and counsel the patient to wait and then take treatment once they are through. But yes, having said that, there are several possibilities. One is absolute sun protection with a very broad spectrum sunscreen which has UVB, UVA, infrared, and visible light protection. Now melasma is considered to be stimulated not only by UV light but also by infrared and visible light. So you should have sunscreens particularly which have a broad spectrum of activity. One, sunscreens have to be used every 3 hours. That's another important thing. You can't just apply it once and then forget about it. Every 3 hours, because it does not last that long. Then there are certain other agents, hypopigmenting agents that can be applied. For example, various alpha hydroxy acids like glycolic acid. We can apply, other these agents, the plant-based agents we can apply, and generally salicylic acid, retinoic acid, hydroquinone is to be avoided, but sunscreens and as I mentioned, the agent glycolic acid, kojic acid, these are safe drugs, safe topicals to be applied during pregnancy. Oral agents should preferably be avoided. Tranexamic acid is a very useful agent. We'll talk about it if you can ask me or other panelists. But tranexamic acid can't be unfortunately used during pregnancy. Otherwise, a very useful drug.
Yeah. Sir, as you just mentioned regarding this, they have to use this role of this tranexamic acid. I will take opinion of everyone. So now this question to Dr. Shetty. Dr. Shetty sir, do you use the tranexamic acid in your practice? Because in our OPD daily we are getting so many company persons are coming. The ma'am, the same tranexamic acid what you are using is very, very much useful. Yes, of course, I tried in some of my patients post delivery, a very, very good results. But what is the exact duration and what's the role of the tranexamic cream also, I want to know.
Well, tranexamic acid is perhaps not the first line of treatment in the management of melasma, but it remains a useful agent in those who show resistance to more conventional lines of medication. And in those refractory recalcitrant cases of melasma, often mixed melasma, which has both an epidermal and dermal component, oral tranexamic acid in the dosage of 250 milligrams twice a day, the plasmin inhibitor, definitely helps a reasonably large majority of these patients. And if somebody is going to respond to oral tranexamic acid, they would do so in first 4 to 6 weeks. If you've not shown a response to tranexamic acid in this period of time, unlikely to respond months later. The challenge really is, how do you manage them once they've responded? If they haven't, of course, you will discontinue medication. But if they do, then perhaps tapering medication or using it in a pulsed manner, meaning you have a period where you use it for a few months, then you switch it off and then bring it back, and so on, has to be planned. Or you could reduce the dosage to half of what is initially recommended. And but given its other potential, if rare, complications that could surface, it cannot be, shall we say, used for extremely extended or long periods of time. Topical tranexamic acid is now being incorporated in a lot of applications. It can also be injected intradermally for melasma. It could be derma rolled using a micro needle apparatus. However, its role orally is where it is proven to work in melasma the best. Topically, yes, but I would not say that in practice. I tend to see the same degree of efficacy as oral tranexamic acid provides.
Okay, thank you so much, sir. So because my query is one more query, because these days some company persons are coming with the tranexamic acid gel along with the combination of some herbal extracts also. Do you recommend these kind of, because yesterday only I met someone who is telling this tranexamic acid gel along with this pine bark extract. So any of our esteemed panelists can throw some light over this. Dr. Meghna, do you use this tranexamic acid gel in your practice for the melasma treatment?
If I tell you honestly, no, it's not my first line of treatment. It falls somewhere back. There's so much more to do with melasma than give topical tranexamic acid. I would agree with Dr. Shetty, sir. Oral tranexamic acid, yes, but topical, rarely do I prescribe.
Okay. And what's your opinion, Dr. Meghna, regarding the use of this kojic acid, arbutin? So many soaps are coming, creams are coming. Patients are so much Google savvy, tech savvy. They are reading somewhere, ma'am, we have read this kojic acid soap. I am applying this kojic acid soap and kojic acid cream also. Still the scars, melasma is there. Patient themselves use the term, melasma is there, still not going. I spend so much of money, I buy this and that thing from the Amazon. So now what to do? So what's your experience with this kojic acid and arbutin?
I agree with you, doctor. Because of this social media, people talk now. The patients are talking in the terminology of actives. They come and say, I'm using this, I'm using that. Gone are the days when we would prescribe something and they would not question. I'm not in favor of soaps being used. They can sometimes be very irritant. Yes, creams. Now, what they are buying is over the counter, or is it a prescriptive one? The percentage would differ between the over the counter product and a prescriptive one. That's where you, as doctors, you must tell them that it's not about how much money you spend, it's about in the right direction. During pregnancy, just follow simple skincare regime, reassurance that most of it in many patients, it resolves as soon as the pregnancy is done with. After that, active management can be done. So don't run after it, especially younger girls. They get very, very beauty conscious. So reassurance that just applying one kojic acid will not help. So do not fall trap into these over the counter or what you buy from Amazon or XYZ. So counseling. Do prescribe sunscreens to them, which is more important. If you tell them why this is happening and how a sunscreen can help you, because melasma is not just hormonal, it's also the ultraviolet and infrared ray exposure, So this has to be explained, as Dr. Ganju said, that you must repeat it every 3 to 4 hours.
Yes.
So I think reinforcement of prevention and certain basic things which can take you a long way are more important than falling trap to buying actives over the counter or from the internet or of these Amazon and all. That's
Correct.
my view.
Correct. Thank you. Thank you so much. Here there is one question from Dr. Seema Chawla. She is writing this regarding sunscreen. Which SPF factor you recommend in your practice? Is 30 or 50?
Okay, I'll take that. Okay, Dr. Shetty, please.
No, go ahead, Dr. Ganju, please.
No, please, sir.
I want
go ahead,
opinion
go
of
ahead.
all of three. I will solve the problem. I will take opinion all of three. Dr. Ganju sir, starting with you.
Okay. Okay. You see, SPF is a very overrated criteria for assessing a sunscreen efficacy. SPF only gives us the protective effect as far as UVB is concerned. But more important in our skins and in pigmentary disorders is the UVA. And now lately they have added infrared and visible light as very important, stimulants, particularly in melasma. So don't look at SPF. SPF of 30 is more than enough to protect you from the harmful effects of UVB. It is more important that UVA protective rating of 3+ or more than that is, or 3-star or more than that is there. And the sunscreen should mention that it is providing protection against infrared and visible light also. So you need to have a broad spectrum sunscreen rather than a high SPF sunscreen. Although higher the SPF, the lesser the quantity of sunscreen you would require. Actually, it compensates for the quantity. Normally, they say that you have to apply a large quantity, which sometimes is not very cosmetically appealing. So that would help with a higher SPF. But SPF is not the only and not a very important component of the criteria of selection of sunscreen. Have a broad sunscreen which gives you protection against all these radiations.
Thank you. Thank you so much, sir. Dr. Meghna, do you want to add something?
I would say, sir rightly said, it's broad spectrum, non-comedogenic, cosmetically acceptable sunscreen, and in Indian patients, which falls in an affordable range.
Correct. Correct. Thank you. Thank you so much, sir. Dr. Shetty, sir, as has just shown in the presentation also. Now, next question I'm taking to you. The dark pigmentation on the breast in pregnancy, how to treat?
You see, like I mentioned, most forms, most pigment changes in pregnancy do not require intervention. They are often self-limiting and to clear up in the postpartum phase. And when you say dark pigmentation in I'm thinking you're referring to the double areola.
Yeah.
Which is going to regress. So I personally would not recommend treatment for this particular entity. Best left alone. Melasma, yes, but for this, the answer would not. Reassurance, eating it out would be the best approach.
Okay. Thank you. Thank you so much, sir. Coming to the next. Friends, please do actively participate in the discussion. Write your queries in the chat box. So Ganju sir, now my next question is for you. We are able to see this kind of face pigmentation. So many patients are coming in the perimenopausal age group. So what will be the line of treatment?
Again, you see the picture is of melasma only, and melasma is stimulated in several phases of life. when there are, drastic hormonal changes happening in the body. One is during puberty, second is during pregnancy, third is during menopause and perimenopausal time also. So this is the time when we can exercise all our options because we are safe. We don't have the problem of pregnancy. So my line of treatment is using a very broad spectrum sunscreen every 3 hours is the first and the foremost thing, and counsel the patient to protect against not only sun, but also heat. You see, going into the kitchen and, doing a lot of cooking also can induce the melanocytes. So that is one, protection from the environmental radiations. Two is we give topical agents like, combination of kojic, arbutin, etc., vitamin C, etc., in the morning. And normally in the night, we start with, in melasmas, severe melasmas, although it's controversial, but initially we can start with a triple combination of a mild steroid and retinoic acid and hydroquinone. And we can start maybe on alternate nights and then reduce it to twice a week. But this combination along with sunscreens gives a very wonderful result. Also, orally give a lot of antioxidants which give them sun protection. And of course, tranexamic acid. Tranexamic acid is very useful in a dose of 250 milligrams twice a day, and gives wonderful results. The only problem is that when you discontinue it, the thing comes back. I also want to add a point about the topical tranexamic acid. Yes, it has not been found to be very useful topically, as useful as orally, most of the studies. But then in patients who have erythema, which is quite common, they apply a lot of things and that causes irritation, redness, erythema. You'll find patients having erythema. In such patients, tranexamic acid topically is helpful because it has a anti-angiogenic effect also. In addition to being anti-pigment, it reduces angiogenesis also. So patients with erythema, telangiectasias, etc., because of steroid abuse or otherwise, or irritated skin, get a good effect out of topical tranexamic acid.
Thank you so much, sir. Dr. Meghna, this question for you. We gynecologists, because our forum is today, we are having a lot of attendance of gynecologists. So this is a very, very common entity. We all are in that. So obstetrician get in our OPD patients, the pregnancy-induced purpura. So which topical therapy would you prefer for this atopic eruptions during pregnancy? And your opinion regarding the use of steroids also.
No, first of all, if there are on oral steroids because of some indication that as doctors you put them on, you have to counsel them. As soon as the drug will be withdrawn, these will settle down. Just have to prescribe very calming agents because it is because of pregnancy. There are no such topical creams which I can tell you that you apply. And for us as dermatologists, most of the topicals fall in category X in my practice. I just counsel them, if required, you can give them a topical vitamin C to, sometimes it works as a placebo. They get very happy. If you tell them no, nothing, go, they will not like it, So as a placebo effect, a topical vitamin C cream up to 20% L-ascorbic acid is available, which can be prescribed. But believe me, reassurance, reassurance, and reassurance.
Thank you. Thank you. Thank you so much. Dr. Shetty, sir, the next question for you. Which is the safest antihistaminic you prefer in your practice? For this pregnancy specific dermatosis, my question is pertinent.
Yes, I think generally pregnancy specific dermatosis, the four categories of this don't in the first place respond very well to oral antihistamines. They're probably better treated with topicals. However, if an antihistamine had to be used during pregnancy, then I think something like a chlorpheniramine maleate, diphenhydramine, or a cetirizine, or loratadine, or fexofenadine could be considered. If the assessment is that the response is unlikely to be significant, I would personally choose not to use them. But if we had to, I would go to chlorpheniramine first before choosing the second generation or the third generation antihistamines. As far as antibiotics are concerned, largely, I think atopic eruption of pregnancy could be managed reasonably well with topical antibiotics if and when need arises, of course, combined with a topical steroid. And the drugs, the topical antibiotics to go to would be either fusidic acid or mupirocin, either alone or in combination with a cortisone or a fluticasone, where appropriate.
Thank you. Thank you so much, sir. Dr. Ganju, sir, you want to add something in this?
No, I think everything has been made clear. I think the safest antihistamine in pregnancy is loratadine, in addition to the first generation antihistamines. The problem with first generation antihistamines is that they are very sedative. Although they are very safe, but they can cause sedation. So out of the non-sedating ones, loratadine is at category B. Rest of them are all category C. Fexofenadine, cetirizine are all category C. So the safest amongst the second generation non-sedating antihistamine is loratadine, and of course the first generation like chlorpheniramine.
Thank you. Thank you so much, sir. So just now we have a very good talk over this by Dr. Meghna. So Dr. Meghna, now this I am coming to you only. So what is the ideal prevention and treatment for striatum gravidarum? Because some of doctors have joined now. So what is your opinion regarding the use of topical hydrolyzed collagen also for in the management of striatum gravidarum? Over to you, Dr. Meghna.
Yes, see, ideal prevention is, just moisturize the skin very well, drink enough water and stop worrying so much, preventative. Yes, you can use over the counter. There are some creams available which may contain, Alicipa or allantoin or, vitamin E creams. Like, people use vitamin E creams, you can do that. Sometimes they come and say, can we use rosehip oil? You can say yes to them. They feel nice, yes. But then none of these can say that if you use this and it will be prevented completely. No, it's all genetically predisposed and other risk factors that we discussed, the pre-delivery weight or the pre-pregnancy weight. And my opinion on topical hydrolyzed collagen, it's not a standalone topical preparation which is available. Many times it's a part of an anti-stretch mark cream which is sold in the market. Yes, it can be given to your patient. There is really no problem there, but I cannot say that it's like, wow, which will not let stretch marks appear.
Ganju sir, your opinion regarding this, because this question was asked to me, one of my pregnant patient. She told me my one of relative is in the US and they are using the topical hydrolyzed collagen. Ma'am, you are writing only stretch nail, bio oil and all this. So what's your opinion for this topical hydrolyzed? So Ganju sir, I want to know your opinion regarding this.
I think there's hardly anything that can be done as far as prevention is concerned, because it's basically a mechanical problem more than anything else. So as the skin stretches, and if you have a bigger, the fetus size is large, the amniotic fluid is large, there's a huge stretching happening, then stria will happen. But of course, if you keep your skin in a healthy state, keep it moisturized, etc., as Dr. Meghna mentioned, lots of fluids, lots of green vegetables, antioxidants, all that, keep your skin healthy, and that may help you, reduce the extent. All the topical applications have been tried and they have shown that they can't prevent stretch marks. They can only reduce the extent of stretch marks to some extent, which includes the hydrolyzed collagen also. So I believe that nothing really will help, but keep your skin healthy with a lot of moisturizers, and keep your system healthy with a lot of fluids, green vegetable intake, vitamin intake, etc. That should go a large way. So once they happen and you are postpartum, then we can think of so many medications, we can think of lasers, we can think of energy-based devices, as Dr. Meghna showed wonderful results after the delivery happens.
Thank you so much, sir. So my other question, Dr. Meghna, would you like to take this? So this is regarding this post-cesarean section scar for the better cosmetic results. Now there are some things coming regarding the silicone gel and silicone sheet is coming for the management of the cesarean section scar. What's your opinion regarding use of that?
First of all, we have to know whether it's a hypertrophic scar, or generally they are hypertrophic, or is it atrophic, or the patient has keloidal tendency.
Yeah.
We must know that. Yes, you can prescribe silicone gel base and you can give them those sheets to apply. Sometimes we do intralesional triamcinolone if it's a hypertrophic scar, because we need to really improve the appearance of the thing. So they are safe, as there is no problem in the safety. It's not that they have to use it very long term. You have to explain to your patient. I generally prescribe for 3 months whenever I put them on any scar treatment. And sometimes, yes, there are a few patients where we had to do the IPL. The ones which were very red, we first did an intralesional Transilon, flattened the scar, put them on the silicone gel to be used at home. Once the scar was flattened, then we did few sessions of IPL to reduce the erythema. I cannot say that it goes away completely, but yes, it can reduce the appearance.
Thank you. Thank you so much. Dr. Shetty, sir, regarding the use of this heparin sodium in the keloid and hypertrophy to scar management, what's your opinion?
I think most of these topical agents for hypertrophic scars or keloidal scars tend to, they're supposed to downregulate the synthesis of new collagen and also to create a more aligned placement of collagen being synthesized by those acutely active fibroblasts. So to have a more regular, orderly placement of collagen rather than haphazard collagen within the scar tissue. It also tends to hydrate the scar. So honestly, if you look at pure evidence from what these creams are purported to achieve, I'm afraid you might not find lots of that. And therefore, whether when one uses what things you've mentioned, I think hydration more than anything else, probably a subjective management of any symptoms that the scar might actually be producing in the form of itch or any kind of discomfort, possibly better. So if you purely by evidence, muted, but in terms of practice, one has to use some topical, so you can choose from a plethora of topical.
Thank you. Thank you so much, sir. Now, next we are coming to our Dr. Ganju, sir. So we are getting a lot of patients of this fungal vulvovaginitis. And now these days, some companies have come with this antifungal sprays also. So my question to you that what is your drug of choice for the management of fungal vulvovaginitis during pregnancy and your opinion on the use of this antifungal sprays?
See, during pregnancy, systemic agents are more or less out. Particularly in the first trimester, you can't give any of the oral antifungal agents. But if you have to, and it is necessary that patient has very extensive disease, then terbinafine can be used from second trimester onwards. It's a category B drug, but should be avoided in first trimester. But the problem is with vulvovaginitis is that it is usually caused by yeasts like Candida, and for Candida, terbinafine is not a very good drug. However, you can use it during second and third trimester of pregnancy. So you depend on topical agents, and topically also you will have to give an azole or something like amrolfin or cyclopyroxolamine rather than terbinafine. Yes, fungal sprays are useful, but I don't think for the mucosal area. The fungal sprays are useful for the groin area, which is usually has a lot of sweat, etc., or is hairy. So fungal sprays are helpful in those situations. But within the mucosa, I don't think it would be preferred. For a mucosa, there should be particularly mucosal preparation like a pessary or something which can be applied inside. But usually prefer an azole rather than allylamine like terbinafine. Azole means something like laliconazole, something like sertaconazole or ibuconazole. They are more effective against Candida, which is the usual causative organism.
Thank you. Thank you so much, sir. Dr. Meghna, these kind of fungal infections we are getting very commonly in pregnancy, the tinea corporis and tinea versicolor. So I want to know your opinion, the drug of choice for that treatment.
Yes, rightly, Dr. Anil Ganju sir said that you have to really try managing with topical preparations, but sometimes they're extensive and topicals do not work. Terbinafine, yes, is a good agent which you can use topically also and orally also. First, you must try orally, topically first, explain to the patient and try. And apart from that, I always try talking about the sugar levels. Some of them have
Yeah.
insulin resistance, or their hygiene levels, as wearing cotton, taking care of perspiration, because you don't want to do very active oral medications with your pregnant patients. So tinea corporis in pregnancy, if it's extensive, my crux is yes, then you can use oral, but try sticking to topical. Sometimes a combination of topicals like allolamine, which is terbinafine in the morning, and azole in the evening, you can even do that. And
Yeah.
tinea versicolor is very, it's a superficial infection. It's nothing to be worried about. It's not, you can just give them some topical, some lotions to apply like half an hour before shower, and again, terbinafine is topically is my drug of choice. And severe pruritus in pregnancy, sometimes I tell them to wear mittens.
Okay. Okay. Thank you so much. So now coming to Dr. Shetty. Dr. Shetty, we are sorry. So this kind of patients we are getting so many, the vaginal dryness and itching in the postmenopausal women. Of course, we start some of the hormonal therapy or some of the height for this. So now menopausal patients with lichen sclerosis atrophicus, I want to know the treatment from you and regarding this recurrent itching in the vagina and perineum.
If you ask me, I'd like to pass this question to Dr. Ganju, who might have treating. I have fairly limited, shall we say, experience. I mean, I wouldn't want to speak from a theoretical basis.
Okay, sir.
I would rather see one of my co-panelists has been treating such patients and achieving outcomes desirable. Dr. Ganju, would you like to take that question?
I think as far as vaginal dryness and itching in the postmenopausal women is concerned, it is usually because of loss of the estrogenic effect postmenopausal area. So they have so many things happening. They have these hot flushes. They have the skin of the body and face getting dry, getting wrinkled. All this you would be treating with oral estrogen. So oral estrogen will help in this also. But lichen sclerosis atrophicus is an autoimmune condition, something akin to what is known as morphia. And this needs to be treated either with topical corticosteroids, but more commonly we use calcineurin inhibitors like tacrolimus and pimecrolimus, and they are quite useful. So we moisturize their skins properly, use either a mild topical corticosteroid for a short period of time, and then take them on to calcineurin inhibitors. They get quite a lot of help. Some patients, earlier there used to be testosterone creams available for this condition, but they are not available now. But good moisturization, mild steroids and calcineurin inhibitors is what I use in this condition.
Thank you so much, sir. Sir, as you have rightly mentioned regarding this testosterone cream, still some papers have come regarding the use of this DHEA gel also for the treatment of, but still all this is offline. Currently, it is not online we are using. Yeah, thank you so much, sir. So any one of our esteemed panelists can take this question regarding this PCOS. The treatment of androgenic alopecia in PCOS, what to use, the minoxidil or any systematic medication, and the dose and duration. This is, I'm talking about the non-pregnant patient first.
Well, number one problem is that in most of the patients of female pattern alopecia in PCOS, the androgens are not the primary agents that are causing this problem. So it has been seen that the DHT pathway that is definitely proven in the male pattern hair loss is not really proven as much in women. In women, there are other mechanisms which include overactivity of aromatase enzyme in the follicles of the hair, which probably is a cause and is a pathogenetic mechanism. So drugs like finasteride, etc., are not the first line in ladies, particularly in the reproductive age group, where finasteride has the problem of staying in the system for a long time and can cause teratogenic effects if they get pregnant. So spironolactone I find to be a very useful agent because it's an end organ receptor blocker, and it can be given orally to these women, although it's not recommended, by the way. The recommendation is only for topical minoxidil. So, but I personally combine oral spironolactone with minoxidil topically. Also, combining spironolactone with OCPs gives a wonderful result. The two together have a very synergistic action. Some patients on spironolactone tend to have menstrual irregularities. That is taken care of by combining with the OCPs, and OCPs by themselves have anti-androgenic effect, and the two together give a very good effect in not only androgenic alopecia but all kinds of hyperandrogenic state induced dermatoses like acne, like hirsutism. Hirsutism particularly for spironolactone is very useful. So this is how I treat these patients.
Thank you so much, sir. Sir, I want to know what dose of the spironolactone you are using, 50 or 100?
You see, we start with 50, 25 BD.
Okay.
And let me tell you, most of our patients do quite well at this dose. But if the patients have not been doing well after about maybe 2 to 3 months, then I go to 100 and usually do not require a higher dose, more than 100.
Thank you so much, sir. Now my next question, this is also a very common questions which we get in our OPD, regarding of hair loss in the antenatal period and the postpartum period hair loss. Even the patient is on all the supplements, yes, in the postpartum period, sometimes it happens the patient suddenly stops the supplement, then starting of the hair fall. But these days, everyone is so conscious and so Google savvy, even though the patients are all on the supplements. But now the patient told me, ma'am, I am taking the protein intake as much as I was in the pregnant. Still, we are getting a lot of patients of this hair loss during antenatal and postpartum period. So any of our esteemed panelists can take this question.
Number one, in the antenatal period, it's a golden period for hair.
Yeah.
They don't get hair loss during the antenatal period. The effect of estrogen is so good. One is that they get a glow. It's called pregnancy glow. In the second and early third trimester, they'll get a glow because of the estrogen effect. And also estrogen has a positive effect on the hair. So generally, hair loss is not seen during pregnancy. Yes, postpartum, it's not because of stopping of supplements. Supplements do not help much in hair fall. It is basically the stress of delivery and parturition that induces the hair loss and suddenly sends the hair follicles into the telogen phase. So lots of hair follicles go into a telogen phase and there is excessive shedding. So postpartum hair loss is very well known because of the stress of pregnancy and delivery. And we generally have to counsel these patients, and this is a very transient and reversible situation. Most of the patients will get out of it within about 6 months, and then they'll regrow their hair. Generally, many things that we use a lot of things, but they're all placebos. They don't have a huge effect on the hair loss per se. So we use a number of supplements, biotin, extra, all useless actually. None of them have a scientific evidence to help, but we do use. But if somebody is deficient in essentials like biotin, etc., then of course we have to supplement. Having said that, we have nothing else to do but to give them supplements. So we give them supplements. Minoxidil preferably should be avoided when there is acute hair loss, because that will add to the hair loss initially. So it's better not to give minoxidil. It's better to give them something like Redancil, which I talked about, some peptide in combination with something like an irritant like Folica, etc., tincture, etc., locally. That helps acute loss more than minoxidil. Minoxidil should be given in chronic loss later on.
Thank you so much, sir. So this we all already discussed. So now coming to this very important entity, friends, those who you have missed, because Dr. Ganju sir very clearly explained in his talk also regarding this hirsutism. So now any of our esteemed panelists can take this question. The treatment of hirsutism in the PCOD, the spironolactone, finasteride, cyproterone acetate. What do you prefer and why? Dr. Meghna, would you like to take this question?
Yeah, my drug of choice is spironolactone. As Dr. Ganju sir rightly said, 50 is the dosage which I really select. I usually keep away from finasteride. I've tried topical finasteride. Recently, I've added because I'm running a laser clinic. From last 15 years, I've been doing laser hair reduction. And for hirsutism, yes, laser is required. No patient can be treated for hirsutism without laser hair reduction. Yes, only laser hair reduction also doesn't help. They do need sometimes a very active intervention. So if you ask me, in my practice, spironolactone is my drug of choice. Talking about the duration, sometimes, 3 months, 6 months, 9 months, 1 year, perhaps 2 years. It depends on the clinical outcome which you're getting.
Thank you. Thank you so much, Dr. Meghna. So, Dr. Shetty, my next question for you is the treatment of this vitiligo type of skin over the vulva. And one first question is this, and the second part of that, the warts and infectious lesions over the vulva in pregnancy and non-pregnant patients, what will be the treatment of choice?
Well, vitiligo, vulval vitiligo is you need to overall understand the context of the condition, figure out where you would classify it, see whether it's progressive, and so on. If it is isolated involvement of the vulva, probably it could be best left alone. However, if treatment is imperative, then the use of topical agents such as tacrolimus, using a decapeptide topically, the use of topical steroid, an appropriate potency topical steroid, and being vulvar, we could even consider the use of narrowband UV in trying to repigment the lesion. But then this is optional, depends on how much it concerns the patient. It is not an absolute, and especially if it is non-progressive. As far as warts are concerned, HPV involvement of or lesions in the vulval area, yes. In fact, if one had pre-existing warts during pregnancy, these are expected to potentially increase in size. But then treatment options are more limited than in the non-pregnant state. The use of topical agents, perhaps it would be a safer option to consider, where appropriate, cryotherapy, radioablation of a wart, and using, like I said, other caustics topically might be considered if the lesions are not very large. But otherwise, I would personally prefer to adopt an interventional procedural entity. When you refer to other infections, I'm not too sure what that means. Would you like to elaborate on that? What's an
No,
infectious
sir, that's
lesions?
okay. Mainly on the warts I want to know. Thank you. Thank you so much, sir.
Okay. All right.
So now coming to the end of our discussion, are very, very important, because this aging gracefully and skin aging and its treatment. I am seeing a very beautiful smile on Dr. Meghna's face, because see, where there is a woman, there is a magic. So I think without discussing this, we can't end our session. So I want to know the opinion of our esteemed panelists regarding on this skin rejuvenation, anti-aging creams and serum, how much they are useful, what's the role of PRP, collagen supplements. I want to know from one by one. I want to take opinion on this for each and everyone. Dr. Anil Ganju, sir.
Well, skin rejuvenation and anti-aging is a huge science, and catching up very, very fast. It's a part of our daily routine now, because there are so many things that are available now for rejuvenation of the aging skin. As far as the anti-aging creams are concerned, what is proven is good moisturizers, particularly the ones that contain hyaluronic acid, etc. There are certain the alpha hydroxy acids, the lactobionic acids, the polybionic acids, They are supposed to, one, hydrate the skin, two, stimulate the collagen also to some extent. Then creams containing vitamin C or serums containing vitamin C have a very good anti-aging effect upon a moisturizer. Then night application of retinoic acid or retinol, very useful as an anti-aging agent, can improve the superficial textural aberrations like wrinkles, like open pores, like slightly loose skin, etc. Role of PRP definitely is there. Again, PRP stimulates the neocollagenosis by stimulating the fibroblasts to produce more collagen. It gives us sheen to the skin. Oral estrogen is your forte. I am not going into that. As far as topical estrogen is concerned, there are some studies which have shown that topical estrogen, along with moisturizers, topical estrogens like estradiol, etc., have been tried, and they do help in improvement of the texture, dryness, etc., in the postmenopausal women. So that's my take on it.
Thank you so much, sir. Dr. Meghna, you want to add something?
As sir has rightly said, this is a huge topic. It requires, I don't know how many hours to talk about it. This is our bread and butter now. Anti-aging, apart from acne, these are the two things which we usually see in our practice. Yeah, talking about women, they start asking questions, when do they start their anti-aging regime? I tell them same thing, use a good moisturizer, use a good sunscreen and a good antioxidant serum, which takes you a long way. Earlier, we never used to talk about serums. Now we do talk about serums, whether it's a vitamin C serum or a retinol serum or a hyaluronic acid serum. But yes, if we go into details, you have to identify the aging process, you have to identify what manifestation, is it laxity, is it wrinkles, is it lines, is it just the facial shape, whatever is bothering them, and then you design the program according to them. PRP, yes, is a wonderful procedure, sometimes standalone, a lot of times in combination with other things. So I think here you need to refer your patient to us.
Thank you so much. Dr. Shetty, sir, do you want to add something?
Yes, both Dr. Ganju and Dr. Meghna have come with their input. So basically, when you look at anti-aging, one must look at what are called 4 R's. You must, wherever applicable, you resurface the skin where necessary. You relax hyperdynamic lines using botulinum toxin. You refill areas of lost volume, and you redrape the skin where there is the gravity-induced skin laxity. So one must take a 3-dimensional view of things. One must understand what works best and customize or tailor treatments for a given situation. And as we understand, aging is never a point on the scale. It is a process. It is inexorable. So treatment plans must not just talk about what is necessary at that point in time, but also what needs to be done over a decade, for example. So it's an ongoing relationship that you share with this patient, and work out the best for him or her. Thank you.
Thank you so much, Dr. Shetty. And thank you to all our esteemed panelists, and big thanks to Acumentis team also. Over to you, Tarunji.
Yeah, good evening, everyone, to the one and all present here. My heartfelt thanks to Honorable Moderator, Dr. Ritu Santwani, our honorable speakers and panelists, Dr. Anil Ganju, Dr. M.K. Shetty, and Dr. Meghna, and all the participants here. It is such an honor for me to get the opportunity to thank you all dignitaries. On behalf of the Acumentis Healthcare Limited, I would like to express my gratitude to all the esteemed delegates of the webinar for their presence and contribution for making this webinar a great success. I must thank the Harmonica team here, the volunteers who are working very hard for the past few days to make it successful. And thank you everyone again for making it a great success. And in case you want to prescribe any of the brands which you feel so like Redensil, which we have the brand name Extra Denser, it is freely available in the market. And I say sometime when I promote to the through my team to the dermatologist, I say I will take the money back guarantee, because this is something which is result oriented brand. And in the last 2 years, it has moved more than 100% growth year-on-year basis. And in addition to this, we have Trenesma. Trenesma is a tranexamic acid, and I have understood the legacy that Dr. M.K. Shetty was the person who launched tranexamic acid in South as a speaker. He was the speaker, and he launched as a pioneer into the Indian market. So Trenesma is there, which is a brand leader, and I mean, having 65% market share. It is available into the combination also. Trenesma 250 milligram BID and Trenesma 250 plus pine bar extract, which is an antioxidant. So generally we are promoting 3 to 6 months therapy for melasma patient. And we do have Acnivar, which is Dapsone brand, and Dapsone with adapalene, Acnivar Plus. We have Misdasan, which is sunscreen, which is SPF 50. It is physical and chemical both sunscreen. So in case you want to use any of the brand personally, do let us know, and the Harmonica team will arrange for you. And let me reassure you, the brand which we are having, they are making waves in the market. And in the last couple of months, I can say the Derma market has bounced back, which was the most affecting to the COVID era. And after COVID, there is a hair fall is there, which has been, the most burning problem. And extra denser has been the, a strong player. And I can assure you, in case if you require this product, you please do let us know, and it will solve the purpose. Thank you very much again. And thank you, panelist and moderator, for slating your valuable time. Thank you so much.
Thank you, Tarunji. Tarunji, I need your number. I also want that for me.
Oh, sure, ma'am. Sure. I will connect you.
Yeah, ma'am, we'll give it to any gynecologist who requires all these products absolutely free of cost. That's our pleasure.
Thank you, Subhajit.
If Shubhajit, it is free of cost, then I cannot take the money back guarantee.
Yeah.
Can
So
you stop sharing the slide? Please stop sharing.
Yeah, I'll pay to you.
What an issue. It is our pleasure to.
Yeah, but a great meeting, ma'am, and really the panel discussion was an excellent one. I mean, everything was covered. Wonderful, sir. Thank you, Dr. Ganju, sir, Dr. Shetty, and everyone were super, actually. Thank you very much.
Thank you so much, and good night.
Thanks, Dr. Ritu. It was really lovely interacting.
Same here, sir. Pleasure is mine.
Thank you, Dr. Shetty and Dr.
Thank
you,
Meghna.
Dr.
Meghna ma'am, you're on mute.
Dr. Meghna, thank you very much.
Thank you so much. Thank you,
Thank
Dr.
you
Ritu.
so
You really added a lot of cheer here. Thank you.
Bye.
Thank you.
Okay,
Thank you.
bye-bye, everybody.
Bye-bye. Good night.
Good night.